The hospital closed, not with a dramatic announcement, not with a movie worthy final day, not with a giant headline that stopped the nation in its tracks. It just closed. The maternity ward had already disappeared years earlier. The specialists left before that. Few services were consolidated somewhere else. A few departments were downsized. Few positions went unfilled. A few doctors retired. Few nurses left. A few budget cuts happened. A few decisions were made in boardrooms hundreds of miles away. Then one day, the community woke up and realized something important. The healthcare system they thought would always be there wasn't. And here's the scary part. That story isn't unique anymore. It's happening all across America, not just in tiny farming towns, not just in isolated communities, not just in places most Americans couldn't find on a map. It's happening in rural communities, suburban communities, small cities, working class communities, places where people assumed healthcare would always exist because it always had. Because healthcare doesn't usually disappear all at once. It disappears one service at a time, one doctor at a time, one department at a time, one hospital at a time. The emergency room closes. Now the nearest ER is 45 minutes away. The OB unit closes. Now pregnant women have to travel to another county. The mental health clinic closes. Now appointments take months. The family physician retires. Now nobody replaces them. And eventually you reach a point where having insurance doesn't solve the problem because there isn't anybody left to use it with. Think about that. We spend so much time arguing about healthcare costs, insurance, copays, deductibles, premiums, coverage. But none of those things matter if care isn't available. Insurance doesn't perform surgery. Insurance doesn't deliver babies. Insurance doesn't diagnose cancer. Insurance doesn't answer 911 calls. Insurance doesn't show up in an ambulance. People do. Hospitals do. Clinics do. Health workers do. And increasingly, many communities are running out of them. That's the conversation we're having tonight. Not just healthcare costs, not just insurance, not just policy, access. Because in America today, your zip code may be one of the most important predictors of your health. The distance between your house and the nearest provider can affect whether a disease is caught early or late, whether a pregnancy is routine or dangerous, whether a mental health crisis gets treatment or gets worse, whether an emergency becomes survivable or fatal. And that should terrify all of us because when healthcare disappears, people don't stop getting sick. They just run out of places to go. Tonight, healthcare deserts, why hospitals are disappearing, and why providers are leaving, why entire communities are losing access to care, and why increasingly your zip code may be helping decide how long you live. Let's begin. Welcome back to Hold 'em Accountable. I'm Derrick Holder, retired Marine, political troublemaker, and someone who has spent the last few weeks walking through some of the biggest pressures facing working Americans. We've talked about utility monopolies. We've talked about wages that haven't kept up with cost. We've talked about health insurance turning illness into a financial emergency. We've talked about the poverty premium and how America charges people more for having less. Tonight, we're talking about something even more fundamental. Because before you can worry about paying for healthcare, you have to be able to find healthcare. Most Americans think healthcare debates are about insurance. Republicans argue about insurance. Democrats argue about insurance. Television argues about it. Campaigns argue about it. Everybody argues about insurance. But here's the uncomfortable truth. Insurance is only one piece of the equation. Healthcare requires three things: a provider, a facility, and access. Take away any of those three and the system starts breaking down. You can have the best insurance in America, but if there isn't a doctor accepting patients, what exactly are you buying? You can have excellent coverage, but if the nearest specialist is 2 hours away, access starts becoming a problem. And if you have a healthcare card in your wallet, but the hospital closed last year, that card suddenly becomes a lot less useful. And that's where millions of Americans increasingly find themselves. Not uninsured, not necessarily underserved, because healthcare deserts are growing. Some communities have no maternity care. Some communities have no mental health care providers. Some communities struggle to attract family physicians. Some have lost hospitals entirely. And some communities technically have healthcare available if you're willing to drive far enough. Now, let's stop right there. Because whenever people hear healthcare desert, they often picture a tiny rural town with one stoplight and a population smaller than a high school football stadium. And yes, rural America has been hit hard, very hard, but that's not the whole story anymore. Healthcare deserts are appearing in urban neighborhoods, working class communities, low income areas, places where the buildings are still standing, but access is quietly disappearing. That's one reason I wanted to do this episode, because people hear healthcare desert and think geography. The real issue is access. A healthcare desert isn't defined by how many people live there. It's defined by whether people can realistically obtain care when they need it. Because here's the thing, a doctor who isn't accepting new patients isn't really available. Specialists with 9-month waiting list isn't really accessible. A mental health provider with no openings isn't really an option. A hospital 90 minutes away isn't much comfort during a heart attack. And that's what makes this issue different from some of our recent episodes. When we talked about insurance, the question was, can you afford care? Tonight, the question is even more basic. Can you get care? Because there is a growing number of Americans who are discovering something frightening. Healthcare doesn't have to become expensive to fail. It can simply disappear. And when it does, the consequences ripple outward. Patients wait longer. Doctors burn out. Nurses leave. Emergency rooms get crowded. Ambulances travel further. Outcomes get worse. Communities become less attractive to families and businesses, and the cycle feeds itself. That's why this isn't just a healthcare story. It's an infrastructure story. It's an economic story. It's a community story. It's a survival story. Because we often talk about healthcare as though it's a product, something you buy, something you consume, something you shop for. But healthcare is also infrastructure, just like roads, bridges, water systems, electricity. You don't think about it when it's working. You only notice it when it's gone. And increasingly, communities across America are discovering exactly what happens when it disappears. So, how did we get here? How did the richest country in the world end up with entire communities losing access to basic medical care? How did hospitals go from community institutions to endangered species? And why are some healthcare systems thriving while others are collapsing? To answer that, we have to go back, because this didn't just happen overnight, and it didn't happen by accident. Let's look at the history. One of the biggest misconceptions about healthcare in America is that hospitals have always been giant regional medical centers. That's not how most communities experience healthcare for much of the 20th century. For generations, hospitals were local institutions, community institutions, the kind of places where people knew the doctors, knew the nurses, and knew the staff. They weren't perfect. They weren't always cutting edge. They didn't perform every procedure imaginable, but they were there. And sometimes there is the most important part of healthcare. Because for most of American history, especially outside major cities, healthcare had a simple goal: get care close enough to patients that could actually use it. Think about America in the early and middle 20th century. Fewer highways, longer travel times, less specialization, fewer transportation options. If a hospital wasn't nearby, people often had no practical way to reach healthcare. So communities, counties, religious organizations, and nonprofits built hospitals. Local leaders fought to keep hospitals open because they understood something that remains true today. Healthcare access isn't a luxury, it's infrastructure. And for decades, that system mostly worked. Not perfectly, but it worked. Small towns had hospitals. County seats had hospitals. Regional communities had hospitals. The hospital wasn't just a healthcare facility. It was often one of the largest employers in town, one of the largest economic engines in town, one of the most important institutions in the town. A hospital meant jobs: doctors, nurses, technicians, support staff, administration, maintenance, food service, emergency services. And it meant security, The knowledge that if something went wrong, help wasn't hours away. But then something began changing. Medicine became more advanced, more specialized, more expensive. Technology improved, which is good. Outcomes improved, which is good. Medical capabilities expanded, which is good. But all those improvements came with a price tag, a very large one. New equipment, specialists, and technology cost money. Compliance and administrative costs increased. Insurance complexity increased. Everything became more expensive. And suddenly, many small hospitals found themselves caught in a difficult position. They were expected to provide increasingly sophisticated care with increasingly limited resources. Then came consolidation. And this is where the story starts becoming familiar. Because if you've watched our utility episode, our insurance episode, or frankly, almost any episode we've done lately, you've probably noticed a recurring theme. Bigger organizations buying smaller organizations. Hospitals and health systems merged. Regional networks expanded. Corporate healthcare grew. Consolidation wasn't entirely bad. Some hospitals gained access to resources they otherwise wouldn't have had. Some facilities survived because larger systems stepped in. Some patients benefited from expanded networks and specialized care. But consolidation also changed how decisions were made. When a hospital is locally controlled, decisions tend to be made locally. When a hospital becomes part of a regional or national system, decisions often move further away. And here's where things get uncomfortable. A local hospital might be viewed as a community necessity. A corporate spreadsheet might view that same hospital as an underperforming asset. Those are two very different perspectives. A community asks, what happens if we lose this hospital? A corporation asks, what happens if we keep losing money on this facility? And once those questions collide, difficult decisions start happening. Departments close, services disappear, staff positions remain vacant, maternity wards shut down, mental health programs shrink, emergency services get reduced. Not necessarily because the community needed them less, but because the financial model became harder to justify. And then another challenge appeared. Population shifts. Many rural communities started losing population. Young people moved away. Employers left. Tax bases shrank. And when population declines, patient volume often declines too, which means fewer paying customers, fewer procedures, less revenue. The costs remain, the patients became fewer, the math became harder. This is not just a rural story anymore, because that's one of the biggest myths in healthcare today, that healthcare access problems only happen in remote communities. Increasingly, urban neighborhoods are facing provider mental health, primary care, and specialist shortages. The buildings may still be there, but access is quietly disappearing. And that's what makes healthcare deserts so deceptive. Sometimes nothing looks different from the outside. The hospital sign is still standing. The clinic still exists. The office is still open, but the wait time is 6 months. The doctor retired. The specialist left. The mental health provider isn't accepting patients. The maternity unit closed. Healthcare hasn't vanished completely. It's simply become harder and harder to reach. And that's often how collapse begins, not with one traumatic event, but with 1,000 smaller losses. Doctor retires, a nurse leaves, a department closes, a budget gets cut, a service moves elsewhere. Individually, each change seems manageable. Together, they fundamentally alter a community's access to care. And that brings us to the question we're wrestling with today. If hospitals were once community infrastructure, what turned them into facilities that increasingly have to justify their existence financially? Because that's where the story really begins, not with hospital closures, but with the economic forces that made those closures possible. That's where we're headed next. If you've been watching the show for a while, you've probably noticed something. Most major problems don't have one cause. They have layers. Utilities didn't become monopolies because of one decision. Housing didn't become expensive because of one decision. Healthcare access isn't collapsing because of one decision. It's a stack of problems. And eventually, the stack becomes too heavy. That's what happened here. Because contrary to what some people think, hospitals aren't closing because Americans suddenly stopped getting sick. Trust me, that is not the problem. People still have heart attacks, still get cancer, still break bones, still have babies, still need emergency rooms, and still need mental health care. Demand isn't disappearing, the ability to provide care is. And it's one of the biggest reasons that healthcare has become increasingly difficult to sustain financially. Now, before somebody clips that sentence out of context, let me explain. Healthcare is unique because, unlike most businesses, hospitals can't simply choose their customers. An emergency room cannot legally decide that heart attacks are too expensive this quarter. A trauma center can't tell an ambulance, sorry, margins are a little tight right now. A maternity ward doesn't get to schedule births based on profitability. Healthcare has obligations that most businesses don't. And that's a good thing. But it also creates financial pressures that many communities struggle to absorb, especially smaller communities, because the costs never stop growing. Everything gets more expensive. Meanwhile, reimbursement doesn't always keep pace. Patient volume doesn't always keep pace. Population growth doesn't always keep pace. And eventually, something breaks. Then we run into one of the biggest healthcare challenges in America today: people, or more accurately, the shortage of people. Let's start with doctors. The average physician workforce is aging. A lot of doctors are approaching retirement. Some have already retired. Others are reducing hours. Others are leaving clinical practice altogether. And replacing them isn't simple. A physician isn't trained in 6 months, or a year, or even 4 years. Medical school, residency, specialized training, licensing, years of preparation. When experienced physicians leave faster than new physicians arrive, shortages develop. And shortages have consequences: longer wait times, fewer appointments, reduced access, more pressure on the remaining providers, which creates more burnout and more departures. That's a cycle we're going to see repeatedly tonight. Then there are nurses. And if the last few years taught America anything, it should have been this: healthcare doesn't function without nurses. Hospitals can have buildings, equipment, technology, administrators, insurance contracts, electronic medical records. None of it matters if there aren't enough nurses. Yet nursing shortages continue affecting communities across the country. Burnout, workload, stress, retirements, career changes, all of it contributes. Once staffing becomes difficult, hospitals start making choices, sometimes painful ones: reduce services, capacity, hours, or just close departments. Not because people stop needing care, because there aren't enough people available to provide it. Then we arrive at one of the least discussed problems in healthcare: specialization. Specialization is amazing. If I need a brain surgeon, I don't want someone who's pretty good at brain surgery. I want the absolutely best specialist available. Modern medicine saves lives because specialists exist, but specialization also concentrates care. The more specialized healthcare becomes, harder it becomes for smaller communities to support every service locally, which means more services get centralized. Cancer treatment moves to larger cities. Specialists move to larger systems. Advanced care moves to regional hubs. Again, there are benefits to that, but there are also consequences, because every service that leaves creates additional distance. And distance matters a lot more than policymakers sometimes admit. 30-minute drive becomes an hour becomes two. Monthly appointment becomes an all-day commitment. A treatment plan becomes a transportation challenge. And eventually people start skipping care, not because they don't need it, because access becomes too overwhelming. Then there's something else we need to talk about, and that's consolidation. Because America increasingly has fewer independent hospitals, fewer independent practices, fewer independent healthcare systems. More and more care is being controlled by larger organizations. Again, there are advantages: shared resources, shared experience, larger networks, greater negotiating power. But consolidation also means decisions become centralized, and centralized decisions don't always reflect local needs. Consolidation also means decisions become centralized, and centralized decisions don't always reflect local needs. A community may desperately need a maternity ward. A spreadsheet may see a department losing money. A community may desperately need mental health services. A spreadsheet may see underutilized resources. A community may desperately need an emergency department. A spreadsheet may see declining margins. That's where the conflict begins because healthcare is caught between two competing realities. It is a service and it is an industry. It is infrastructure and it is a business. It is a public necessity and it exists within a financial system. And the tension between those realities is driving many of the challenges we're seeing today, which brings us to the hardest truth of the night. Healthcare deserts are not really about geography, not at their core. They're about access. That's why this issue keeps growing despite all of our medical advances. We're better at treating disease than we've ever been, better at surgery, better at diagnostics, better at technology, better at medicine. And yet, millions of Americans are struggling to access those advancements, not because the care doesn't exist, because it exists somewhere else. And that's where the story gets personal. Because when distance becomes a barrier, geography starts affecting outcomes. And once geography starts affecting outcomes, your zip code begins influencing your health. That's not a healthcare financing problem. That's a healthcare access problem. That's where we need to focus next. Because the reality people are living right now is even more alarming than the history. Let's make this personal because up until now, we've been talking about systems, hospitals, economics, consolidation, provider shortages, all important, but none of those things matter as much as what happens when a real person needs care because healthcare deserts aren't really measured in miles. They're measured in outcomes. A hospital closure isn't just a building closing, it's extra time. A doctor shortage isn't just a staffing problem. It's a delay. A specialist shortage isn't just an inconvenience, it's a barrier. And sometimes those extra minutes, extra weeks, or extra months become the difference between a manageable problem and a serious one. Think about cancer. Early detection saves lives. We've known that for decades. The sooner a problem is identified, the more options doctors have available, and the more treatment paths exist, the better outcomes tend to be. But what happens when the nearest specialist is 2 hours away? What happens when appointments take months to schedule? What happens when transportation becomes part of the treatment plan? Because eventually access itself becomes a healthcare issue. That's one of the things people in major metropolitan areas sometimes struggle to understand. Healthcare isn't just about whether a doctor exists, it's about whether that doctor is realistically reachable. A specialist 3 hours away might as well be on another planet for some families, especially if transportation is unreliable, especially if childcare is needed, especially if taking time off work means losing income, especially if the appointment isn't one visit, but 10 or 20 or 50. Now let's talk about maternity care. Because this is one of the most alarming trends in healthcare today. Across America, maternity wards have been closing, particularly in rural communities. And when maternity care disappears, pregnant women don't stop getting pregnant. They just travel further. Think about how absurd that sounds. A community loves its maternity unit. The nearest labor and delivery department is now an hour away, maybe longer. Everything is fine until it isn't, because babies are famous for not respecting travel schedules. Labor doesn't care about construction delays. It doesn't care about weather, doesn't care that the nearest hospital is in another county. And yet, thousands of families are increasingly facing exactly that reality. And here's the thing, when maternity services disappear, they rarely disappear alone. Pediatric care, women's health care, and preventative care often becomes harder to access. The entire healthcare ecosystem starts weakening. One closure creates another problem, which creates another problem, which creates another problem. The pattern should sound familiar by now because we've seen this in every episode this season. Small losses accumulate and eventually the entire system looks different. Now let's talk about mental health care. Because if there's one area where healthcare deserts may be most visible, it's mental health. Many communities across America simply do not have enough mental health providers, not enough psychiatrists, psychologists, counselors, or therapists. And when demand exceeds supply, wait times grow. Weeks become months, months become larger. People give up. People stop looking. People don't get help. And unlike some healthcare conditions, mental health challenges often become more difficult to treat the longer they go unaddressed. I've spoken publicly before about PTSD. I've spoken publicly about therapy, about mental health, because I know firsthand that asking for help can be difficult. The system shouldn't make it harder. If someone finally finds the courage to ask for help, the response shouldn't be, maybe we can see you in 6 months from now. That's not access. That's a waiting list. Sometimes waiting lists have consequences. Then there are emergency services. That's where geography becomes brutally simple. If someone is having a heart attack, distance matters. Someone is having a stroke, distance matters. If someone is bleeding, distance matters. And if somebody injures themselves farming, distance matters. This isn't politics. This isn't ideology. This isn't a debate. It's biology. There are emergencies where minutes matter. Literally, minutes. Every additional mile, minute, or delay can affect outcomes. And that's what makes hospital closures so different than most other economic decisions. When a grocery store closes, that's bad. When a factory closes, that's bad. When a retail store closes, that's bad. When a hospital closes, people can die. Those are equivalent consequences, which is why healthcare cannot be evaluated solely through the lens of profitability. Because communities don't just lose a building when a hospital closes, they lose capacity, resilience, security, and time. And sometimes time is the one thing medicine cannot replace. Now, here's the line I want people to remember from this entire segment. For some Americans, the first symptom isn't illness, it's geography. Before the diagnosis, the treatment plan, the prescription, the surgery, or the recovery, the first challenge is simply reaching care. And that is a reality millions of Americans are living with right now. Not because they're uninsured, not because they don't care about their health, not because they're making bad decisions, because of where they live. And once your zip code starts affecting how quickly you can access care, how often you can access care, whether you can access care at all, you're no longer talking about a healthcare system that's merely stressed. We're talking about a healthcare system that's developing holes. Now we get to the receipts, because everything we discussed so far can sound anecdotal. Hospital closes here, a doctor retires there, maternity ward disappears somewhere else. It's easy to hear those stories and assume they're isolated incidents, exceptions, bad luck. The data says otherwise. The data says we're looking at a pattern. Once you see the pattern, it's difficult to unsee it. Let's start with the most visible example, hospital closures. According to researchers tracking healthcare access across the United States, well over 100 rural hospitals have closed since 2010, with many more operating under severe financial strain. Numerous studies have also identified hundreds of additional rural hospitals as financially vulnerable. Think about that. We're not talking about one region, one state, one isolated problem. We're talking about a long-term national trend. And every time a hospital closes, access shrinks, not for one patient, for entire communities. Now let's talk about one of the most alarming healthcare trends in America, maternity care deserts. Entire counties where women have little or no local access to OB care, no hospital-based labor and delivery services, no OB providers, no nearby maternity infrastructure. Millions of women now live in counties that face significant maternity care access challenges. Think about how extraordinary that is. We have technology capable of performing robotic surgery. We can transplant organs. We can sequence DNA. Yet there are communities where giving birth safely requires crossing county lines and driving long distances. That should concern everyone. Let's move to mental health care. Because if you look at federal shortage maps, huge portions of the U.S. are designated as mental health professional shortage areas. Not because nobody needs care, because there aren't enough providers. This is one of those statistics that sounds abstract until it becomes personal. Tell someone you care about needs help. Tell someone finally decides to seek treatment. Tell someone finally reaches out and then discovers there aren't enough providers available. or that appointments are months away, or the nearest option is hours away. It's not a theoretical problem, it's a real world barrier to care. And that barrier can lead to some horrific circumstances. Now, let's talk about doctors. For years, healthcare organizations have warned about physician shortages driven by population growth, workforce aging, retirements, and increasing demand for care, particularly in primary care, because primary care physicians are often the front door to the healthcare system. When the front door disappears, everything behind it becomes harder to reach. The result? Longer waits, reduced access, fewer appointments, more pressure on existing providers, and eventually more burnout, which creates even more shortages. Now, let's talk about something that's almost common sense. Distance matters. Numerous studies have found that longer travel times and reduced healthcare access are associated with delayed care, missed appointments, or reduced preventative care utilization, and poorer outcomes in certain populations. In other words, when care gets further away, people use less of it, not because they don't care, but because access becomes harder. This shouldn't surprise anybody. If every appointment requires half a day off work, people postpone appointments. If specialists require multiple hours of driving, people delay treatment. If transportation becomes part of the healthcare challenge, fewer people receive care. It's not ideology, it's reality. And finally, let's talk about the people holding the system together: doctors, nurses, paramedics, therapists, technicians, support staff. The people who kept showing up during a pandemic, the people who continue showing up today. Burnout remains one of the most significant workforce challenges in healthcare. People retire, people leave, people change careers, people reduce hours, and every departure increases pressure on those who remain. And that's what ties all of these receipts together: hospital closures, provider shortages, maternity care deserts, mental health care deserts, longer travel times, workforce burnout. These are not separate stories. They are symptoms of the same underlying problem: a healthcare system that's becoming increasingly difficult to access in many parts of America. Not because people need less care, not because medicine stopped advancing, not because Americans became healthier, because the infrastructure supporting care is under strain. And eventually, every system reaches a point where stress becomes visible. The question is, what do we do about it? Because if healthcare access is becoming a structural problem, then we need structural solutions. And that starts with recognizing something we've forgotten. Healthcare isn't just a service, it's infrastructure. And we should probably start treating it that way. Now comes the part where somebody says, okay, Derek, you've spent the last 40 minutes explaining why healthcare access is collapsing in parts of America. What's the solution? Fair question, random somebody. Because identifying the problem is important. Solving it is the point. And before we start, let's acknowledge something. There is no single solution, no magic pill, no executive order, no one size fits all answer. Healthcare deserts weren't created by one problem. They're the result of dozens of problems stacking on top of each other over decades, which means fixing them will require addressing multiple issues at the same time. But I think we should start with a simple shift of thinking, one that sounds obvious once you hear it. Healthcare is infrastructure, not metaphorically, literally. We already understand this concept when it comes to roads. No one expects every road to generate a profit. Nobody looks at a rural bridge and says, well, not enough cars crossed it this year. Tear it down. Nobody evaluates a fire department based solely on revenue generation. Nobody asks whether a water treatment plant is maximizing shareholder value, because we recognize that some things exist because communities need them. Healthcare belongs in that category. And yet, we've increasingly built a system where healthcare facilities are expected to function like businesses first and infrastructure second. That's where many of these problems begin. Now, before somebody accuses me of being anti business, let me stop you right there. Healthcare costs money. Hospitals need budgets. Employees deserve fair pay. Equipment isn't free. Buildings aren't free. Nothing about healthcare is free. This isn't an argument against economics. It's an argument against pretending economics is the only thing that matters. Because if profitability becomes the sole measurement of success, eventually every unprofitable community loses. That's exactly what we're seeing. The hospital that serves a struggling county, the maternity ward that serves a rural region, the mental health clinic that doesn't generate massive revenue, the emergency department that must stay open whether it's profitable or not. These aren't luxuries, they are necessities. And necessities shouldn't disappear simply because a spreadsheet doesn't like them. Next, we need to talk about healthcare workers because all the buildings and all the world don't matter if nobody is inside them. We need more doctors, more nurses, more therapists, more mental health providers, more specialists willing to practice in underserved communities. Honestly, I think we need to stop treating healthcare workforce shortages like they're mysterious. People follow incentives. If communities need providers, then we should create incentives that make serving those communities attractive. Loan forgiveness, scholarships, residency programs, recruitment initiatives, retention programs. There are already efforts doing some of this. We need more of them because if we don't solve the workforce problem, every other solution becomes much harder. Then there's telehealth. Now, telehealth isn't a miracle. A Zoom call cannot perform surgery. A webcam cannot deliver a baby. An app cannot replace an emergency room. But telehealth can help close gaps, especially in mental health care, primary care follow ups, specialist consultations, medication management. For communities facing provider shortages, every additional point of access matters. The goal isn't replacing healthcare workers, the goal is extending their reach. And frankly, it's one of the few areas where technology may genuinely help reduce healthcare deserts, not eliminate them, reduce them. That's progress. Then we need to have the difficult conversation about consolidation because larger healthcare systems are not automatically bad. Some hospitals survive because larger networks support them. Some communities benefit from shared resources. Some patients gain access to services that otherwise wouldn't exist. But we also need to ask, at what point does consolidation stop serving patients and start serving balance sheets? Because communities deserve a voice when healthcare decisions affect their survival. A maternity ward closure isn't just a business decision, it's a community decision. Hospital closure isn't just a financial decision, it's a public safety decision. An ER closure isn't just a budget decision, it's a life and death decision. Those realities should matter. And maybe the most important thing we can do is change the way we talk about healthcare access. Because healthcare deserts are often discussed as though they're unfortunate inconveniences. They're not, they're infrastructure failures. If a community loses clean water, we treat it as an emergency. If a bridge collapses, we treat it as an emergency. If the electrical grid fails, we treat it as an emergency. Why should healthcare access be any different? Because ultimately, that's what we're talking about, access. Not whether a hospital has the latest equipment, not whether a healthcare system posted strong quarterly earnings, not whether a corporation met its projections, whether people can get the care when they need it. That's the question. Everything else is secondary. And if we're serious about solving healthcare deserts, that's where we have to start. Because when somebody is having a stroke, they don't care about market forces. When someone is in labor, they don't care about quarterly reports. When someone is having a mental health crisis, they don't care about shareholder value. They care about one thing: can they get help? That's the standard we should be using. And right now, in far too many communities, we're failing it. You know the rules. If it improves access to care, strengthens communities, and helps people receive treatment when they need it, we hold them. If it makes healthcare harder to reach, weaker, or more dependent on luck and geography, we fold them. Tonight, we're talking about the systems that determine whether care is available before a patient ever walks through the door. Let's begin. Let's start with the obvious one. When a community loses its hospital, it doesn't just lose a building, it loses options, loses capacity, it loses specialists, jobs, emergency access, time. And time matters. especially in healthcare. Now, I understand that not every hospital can operate indefinitely under every circumstance. Reality exists, budgets exist, economics exist. But when communities lose healthcare infrastructure, the consequences don't disappear just because the accounting problem was solved. The people remain. The medical emergency remains. The pregnancies, illnesses, and need all remain folded. Healthcare absolutely has economic realities. Hospitals need budgets. Employees deserve paychecks. Equipment costs money. But if profitability becomes the only measure of value, we're going to keep watching essential services disappear. Nobody asks whether a fire station is profitable. Nobody asks whether a police department is profitable. Nobody asks whether a bridge is profitable. Some things exist because communities need them. Healthcare belongs on that list. Fold the mindset that healthcare's value can be measured only through financial statements. This one deserves its own category because when maternity ward closes, doesn't just affect childbirth, it affects prenatal care, women's health care, pediatric care, family health, entire communities. And unlike many healthcare services, labor has a habit of operating on its own schedule. A woman in labor should not have to calculate whether she has enough time to drive to another county. That shouldn't be normal. Yet, in parts of America, it increasingly is. Fold it hard. This one isn't about hospitals, it's about us. Because healthcare deserts don't appear overnight, they grow quietly. One closure, one retirement, one department, one service, one provider at a time. And sometimes communities don't realize what's happening until the system is already in crisis. We assume someone else is paying attention, someone else is planning, someone else is protecting the infrastructure. Then one day we need care and discover there isn't enough left. Healthcare access is one of those issues that becomes everybody's problem eventually. Fold the complacency. This one shouldn't be controversial. If a community needs healthcare, we should invest in healthcare. Not because every facility is profitable, because every community deserves access. That doesn't mean every town gets a major trauma center. It means every American deserves a reasonable opportunity to receive care. Hold it. One of the most effective healthcare tools we have doesn't always get enough attention. Community clinics, primary care, preventative care, basic treatment, mental health care, chronic disease management. These clinics often fill gaps before the gaps become emergencies. And that's exactly what good infrastructure is supposed to do. Hold it. Now let's be realistic. Telehealth is not magic. It cannot replace every doctor. It cannot replace every hospital. It cannot perform surgery through a laptop. But it can expand access, particularly in underserved communities, particularly for mental health, particularly for follow up care. Technology should bring care closer to patients whenever possible, not further away. Hold it. This may be the easiest hold of the night. Doctors, nurses, paramedics, therapists, technicians, support staff. The people who keep showing up. The people who stay through the pandemic. The people who continue holding together a strained system every day. They are not the reason healthcare access is struggling. Many places, they're the reason healthcare access still exists at all. Hold them every single time. So tonight's scorecard looks like this. Fold, hospital closures, treating healthcare solely as a business. Maternity ward closures, the idea that someone else will solve the problem. Hold, rural healthcare investment, community clinics, telehealth, and healthcare workers. Because at the end of the day, healthcare deserts aren't really about hospitals. They're about access. They're about whether help exists when people need it. They're about whether a person's future is determined by their diagnosis or their address. And that brings us to the most important part of tonight's conversation, because this episode isn't really about buildings or budgets or staffing shortages. It's about something much more fundamental. What it means to live in a county where geography increasingly determines opportunity and sometimes survival. One of the things I've noticed about healthcare is that it has a way of cutting through politics faster than almost anything else. Because when you're healthy, healthcare is a debate. When you're sick, healthcare becomes personal. When it's an emergency, Healthcare becomes immediate. Nobody having a heart attack stops to ask whether the ambulance coming to help them is a conservative or progressive. Nobody having a stroke asks whether the emergency room voted Republican or Democrat. Nobody in labor asks which political party runs the hospital. The ambulance doesn't care about politics. The ER doesn't care about politics. The diagnosis doesn't care about politics. And the human body certainly doesn't give a fuck about politics. Yet somehow access to healthcare increasingly depends on something just as arbitrary: your zip code. Think about that for a moment. Two Americans have the same illness, the same symptoms, the same diagnosis, the same need for treatment, yet have dramatically different outcomes based largely on where they happen to live. Not because one person works harder, not because one person is more deserving, not because one person made better choices, because one person lives 20 minutes from care, the other lives 2 hours from it, because one community still has a hospital, the other lost theirs, because one area can attract physicians and another can't, because one patient can get an appointment next week and another has to wait 6 months, because one is in Martinsville, the other is Indianapolis. And in fact, access may be the most overlooked healthcare issue in America because we spend so much time arguing about insurance cards that we sometimes forget a simple truth. Healthcare doesn't happen on paper. Healthcare happens where patients and providers meet. Everything else is just administration. A health insurance card cannot deliver a baby. A policy document cannot treat depression. A deductible cannot diagnose cancer. A reimbursement rate cannot respond to a heart attack. People do those things. Hospitals do those things. Clinics do those things. Healthcare workers do all of those things. And when those resources disappear, communities become more vulnerable, whether they realize it or not. And one of the things that stuck with me while researching this episode is how often hospital closures are discussed like economic news. A facility closes, a service line closes, a department closes, a provider retires. And on paper, that's how it looks. But on the ground, those aren't business stories. They're community stories. They are the story of a pregnant woman who now has to drive to Greenwood or Bloomington or Indianapolis, a senior citizen who now has to travel to Kokomo, to Terre Haute, to Fort Wayne, a family that now has fewer options during an emergency. That's the real impact, and it rarely shows up in a quarterly earnings report because healthcare access isn't just about healthcare. It's about community viability. A town with healthcare attracts families. A town with healthcare attracts employers. A town with healthcare attracts retirees. A town with healthcare creates stability. Take healthcare away, and eventually other things begin leaving too. The employer wonders if workers can access care. Families wonder if they should move. Doctors wonder if they should stay. Businesses wonder if they should invest. The loss of healthcare doesn't just affect patients, it affects the future of an entire community. And that's why I keep coming back to the same conclusion. Healthcare is infrastructure, not because it sounds nice, not because it's politically convenient, because it is what it is. We understand that roads connect communities. We understand that water systems sustain communities. We understand that electrical systems support communities. Healthcare does all of those things in a different way. It keeps communities alive, literally. And once we start thinking about healthcare that way, some of our priorities begin to change. The question stops being, is this facility profitable? And starts becoming, what happens if it disappears? Because that's the question communities across America are increasingly being forced to answer. And sometimes the answer is uncomfortable. Longer drives, longer waits, fewer providers, fewer services, worse outcomes, more risk. Not because medicine failed, not because science failed, not because healthcare workers failed, but access failed. And maybe that's the biggest lesson from tonight. When people talk about healthcare, don't just ask whether someone has insurance. Ask whether they have care. Those are not always the same thing. Because when healthcare disappears, people don't stop getting sick. They don't stop having emergencies. They don't stop having babies. They don't stop needing treatment. They simply run out of places to go. A hospital closure isn't just a headline, it's a warning that a community is losing one of the most important pieces of infrastructure it has. And once that infrastructure is gone, getting it back is a lot harder than keeping it in the first place. So, whether you live in a rural community, a small town, a suburb, or a major city, this issue matters because healthcare deserts don't stay contained forever, and because someday every one of us will need care. The question is whether it will still be there when we do. So stay informed, ask questions, and as always, hold them accountable.